We all know that kids should grow, thrive, and live long, healthy lives. As pediatricians, we have the unique opportunity to make a difference for our patients and families by identifying and supporting young people who are at risk for suicide. During routine visits, we can follow a 3-step clinical pathway by conducting a screening, making a safety assessment, and identifying next steps of care. The first step is universal suicide screening using a validated screening tool. The American Academy of Pediatrics recommends universal suicide screening of all patients in every demographic and every setting who are 12 years and older. Screening for depression is important, but might not be sufficient. Universal suicide screening is the best way to identify kids at risk. And any member of your clinical team trained in administering a screening tool can start by taking about 20 seconds during the visit to talk about suicide. This can become part of your workflow or added to your EHR. Ask thoughtfully and directly, have you been having thoughts about killing yourself? Listen to their answer to help inform your next step. Once you know a patient is at risk for suicide but not in imminent danger, ask in subsequent visits. Last time you were here, you told me you had some thoughts about suicide. I wanted to check in with you about that. Remember, screen patients at least once a year, even for those who have no history of suicide risk. Most young people keep suicidal thoughts to themselves and might not bring this up on their own if they aren't asked a direct question. Even a patient presenting with other health concerns or simply coming in for a regular checkup can have pressing mental health concerns that they aren't talking about with anyone. Without these direct conversations, our patients might pass through their visits with us without really being seen. In the next video chapter, I'll go through the second step to take when your patient has a positive screen. Let's say you have a patient who told you that they have thoughts about killing themselves. The next step is to conduct a brief suicide safety assessment, or BSSA, to help you decide whether it's safe to send them home or whether there's a need for immediate intervention. You and anyone in your practice, such as a nurse practitioner, physician assistant, or mental health professional, can perform a BSSA after proper training. A BSSA is a 10 to 15 minute conversation with your patient that helps you evaluate their personal risk and protective factors related to suicide. It includes your patient in the decision-making process for their treatment options and sends a message that mental health care is a collaborative process. To start, you might ask how often they think about suicide, if they have specific plans, or whether they've attempted suicide before. Ask if they've thought about reasons to live and what social support systems they have. If your patient screens positive for suicide risk, tell them carefully and thoughtfully. Explain that you will need to talk with their parents or caregivers and ask them how they would like to be involved in that conversation. When talking with parents or caregivers, ask if they know about their child's suicidal ideation or behavior in a way that does not come across as blaming or judgmental. You might say, "Your child spoke about having suicidal thoughts. Is this something they've shared with you?" Be aware that young people are often private about their suicidal thoughts, and it's common for parents to be unaware of this. The BSSA is important because you want to provide care that matches the level of risk unique to the patient and not to over-respond. Not every conversation will lead to a full safety precaution response where your patient goes right to the emergency department and is admitted with a one-on-one observer or sent to a psychiatric unit. This response is only meant to keep kids safe who are at imminent or acute risk of harming themselves. Regardless of level of risk, all patients and their parents should be given the 988 Suicide and Crisis Lifeline and Crisis Text Line. Consider texting the line with your patient while they are in the office to help them feel comfortable and familiar with the service. Those patients who aren't in imminent danger do not require safety precautions, but may or may not need further evaluation. I'll cover high, medium, and low risk levels in the next video chapter. With your patient in the office, you've completed the suicide risk screening and the brief suicide safety assessment, or BSSA. The next step is to identify your patient's level of suicide risk. With a trauma-informed care approach, talk with your patient and their parents or caregivers. If they have current active suicidal thoughts, then they are at high risk and will need emergency psychiatric evaluation. While they're in your office, employ safety precautions, like keeping them under direct observation and removing dangerous items from the room. If there isn't a mental health professional on site, send your patient to the emergency department or engage a mobile crisis team or acute mental health evaluation center. Continue the conversation with compassion and reassurance. Listen openly and patiently without judgment. You can say things like, "Thank you for telling me how you're feeling. It was very brave to share those thoughts. I'm here to help you. You don't have to go through this alone." It's important to explain that their safety is your number one priority and that you're going to keep them safe while you get them the help they need. Be sure they understand that the steps you're taking are to protect them, not to punish them. If your patient has suicidal thoughts but is not currently and actively considering suicide, then they aren't at imminent risk. They might not have a plan for how they would kill themselves or have immediate access to lethal means. They are considered moderate risk for suicide and need a full mental health evaluation. If mental health evaluation is not available within your practice, refer the patient to an outpatient mental health clinician. Your assessment conversation may reveal that your patient is at low risk for suicide. For example, maybe they disclose suicidal thoughts or attempts from long ago and now have strong supports in place. If this is the case, they may benefit from future mental health care, but current risk is low. Sometimes suicide risk screening tools pick up other mental health concerns, such as anxiety, distress, PTSD, or angst that may not be related to your current suicide risk. In these cases, your patient might benefit from further mental health care, but they are not at imminent risk for suicide, and you can send them home with a mental health referral. Provide parents or caregivers with resources to support them, including the 988 Suicide and Crisis Lifeline. Regardless of risk level, you should follow up with your patient and their family after the visit. Call within 72 hours to ask if they've connected with mental health treatment. We all know that kids should grow, thrive, and live long, healthy lives. Under our care, those who are struggling with suicidal ideation can receive the support they need to boost their strength and resilience.